I am a pediatric orthopedic surgeon who focuses on upper extremity at University of Maryland School of Medicine. And welcome to tonight's webinar, our second in our series that's focusing on pediatric forearm, wrist, and hand trauma. As everyone knows, these webinars will be weekly in nature, and we'll go from 7 to 8:30 during April. In May, we will switch to 7 to 8 o'clock at night. We did do the first webinar 2 weeks ago on pediatric elbow fractures. And then next week we'll be on congenital pediatric extremity conditions. And then we'll move into adult hand conditions, as you can see listed here, with compression neuropathies followed by brachial plexus injuries. And then we'll keep filling in as time goes on during this crisis. Please note the link at the bottom. You can copy it down. This is the link to register for all of these webinars, as well as just all of the recordings in case you missed one. And I will show that link at the end tonight as well. When we break away from pediatric conditions, we will also be starting pediatric orthopedic webinars through my institution. And again, you can write down this link as well. These will follow directly after these hand lectures from 8:15 to 9:15 Eastern Time. However, these will be in a different platform, so you'll have to end your Zoom and go to a Teams live event, and we'll start those again in May. May 3rd will be pelvic and femur fractures, and May 10th will be leg, ankle, and foot fractures. So again, tonight we have an awesome, well-respected, national and internationally known lineup of presenters. We'll be starting our conversation on finger fractures from Dr. Cornwall from Cincinnati Children's. We'll then move to metacarpal fractures with Dr. Christine Ho from Texas Scottish Rite. We'll then go to the carpus, where Don Bay from Boston Children's will focus on scaphoid fractures. I'll then talk about distal radius fractures. We'll move more proximal to the forearm, where Dr. Herman from St. Christopher's Hospital for Children of Philadelphia will discuss those. We'll then go on to amputations and replantations from Teresa Ryrick from Arkansas Children's Hospital. And then we'll end with tendon injuries from Scott Cozen from Shriners Hospital for Philadelphia. And there's Scott. He'll take us home on his elephant. So again, the hand and upper extremity webinars, you can go to this website, as you see listed here. And this will be for all of the AAHS run webinars and the pediatric orthopedic webinars. You can see that site there listed for those. So with that little intro, we'll start right away on finger fractures from Roger Cornwall.
All right, good evening, everyone. I hope everyone is safe at home. This will take 1 second here.
Roger?
Yes.
Can you turn that off for a second?
Stop
Can you
share?
stop share? Yes.
Yep.
Apparently, I just got a text from my residents that they couldn't see a thing I was doing.
Right,
So,
only the program was visible.
got it. Sorry about that. All right, let's see if this works now. Are we good now? Everyone can see? Sarah?
Yes.
Yes, great. Okay, so sorry about that. Thank you, Dr. Weber. I'll just jump then. Here's everyone's picture for anyone that wants to know. Again, this will be Roger Cornwall on fingers, Christine Ho on metacarpals, Don Bay on scaphoid, myself on distal radius, Marty Herman on forearm, Teresa Wyrick on amputations and replantations, and Scott Cozen on tendon injuries. And here's Scott bringing us home on his elephant. Sorry about that. Okay, so here are the websites. I'll just leave those up for 30 seconds here. I'll put them up at the end again. You should all be getting emails following your registration anyway, at least for the AHS one. And we'll probably be able to post this site either on AHS or we'll send an email with that as well. but I'll show them at the end so they're not running crazy late. So I'll stop sharing now and let Roger take over. Sorry about that.
Okay, that's great. Thanks, Josh. And thanks for pulling that back up. I think we were all pretty confused when you started talking about Scott Cozen's elephant. Okay, everyone can see my slides here?
Yes.
Fantastic. All right, so I'm going to take you on a whirlwind tour of pediatric hand trauma focusing on phalanx fractures. I have no pertinent financial conflicts of interest, although I'm excited to announce that the Hand Society will be coming out with a textbook entirely dedicated to pediatric hand trauma that a whole bunch of people, including some on this call, have contributed to. So thank you for that. I'm really excited to have that coming out soon. So the purpose of this talk is really to give a broad overview of pediatric finger fractures with some attention paid in the beginning to evaluation and initial management pearls and pitfalls. But I'll talk about the definitive treatment decision-making of a whole variety of injuries, if for no other reason than to give you an appreciation for the variety of injury type and severity in the pediatric finger. So of course, it's not surprising that the hand and wrist is the most frequently injured part of the child's body, and depending on where you draw the line, is 10 to 20% of all fractures. And that incidence tends to be increasing somewhat, either because of increased sports participation in older children or household injuries in young children. And we've certainly seen a bump in those over the last few weeks. Now, about half the fractures in children's hands are non-displaced, and about 2/3 don't involve the physis, so about 3/4 of them are pretty benign fractures, and you can do whatever you want. But the key is to recognize the problem injuries and treat them appropriately. And to do so, a physical examination is really an important step, but it's a very difficult thing to do. Examining the hand is tricky to begin with, but in a child's hand, especially an injured hand, they can't communicate what's wrong or answer difficult questions or even follow commands. And sometimes they're just afraid and in pain. And so it's important to have an armamentarium of passive tests and clinical signs, things that you can do from across the room that don't require engaging the child. And there are a number of these different pearls, but really focusing on those pertinent to finger fractures, I think the most important one is using wrist tenodesis. So passively extending the wrist to flex the fingers so that you can pick up rotational malalignment, such as this proximal phalanx neck fracture that was looked non-displaced on radiographs, but was actually rotationally malaligned. And then as far as imaging the hand, it's always important to get specific finger images. Although you may be able to see a fracture on the AP, you won't be able to fully evaluate it unless you have a dedicated lateral of that finger. And in fact, in a Simmons and Hastings article from the 80s, the leading cause of poor outcomes in phalangeal neck fractures was an inability to appreciate the sagittal displacement based on an x-ray of the hand instead of an x-ray of the finger. And so a dedicated lateral of each finger, you can splay them if you need to, if there are multiple fingers injured, but that's not ideal. It's better to get a dedicated lateral of each finger. And then the initial triage or splinting can be done. Splints can even be used as definitive treatment when symptomatic treatment is all that you need, such as a stable buccal fracture of a proximal phalanx base. But really, if immobilization is critical for the success of your treatment, such as this displaced Boxer's fracture that was beautifully reduced and came back 10 days later with the child saying, "I swear to God, doc, this is how they put it on." Right, not so much. So if immobilization really is crucial, then a cast is what you need. And you can't just cast a finger. I mean, you can, but it's rare that you would ever do that. And so don't hesitate to cast more than you think you need, because you'll know that your proximal phalanx neck fracture that was pinned here will come back for pin removal, having been to Sky Zone and gotten your trampoline park tattoo there. So that's something you have to protect them against. And in young children, taking a cast above the elbow is never a problem. In an uninjured elbow, it doesn't cause stiffness, and it prevents it from coming off. And it's not just in the infants. Here's a 6-year-old with a skinny hand who slid her below elbow cast off quite nicely, and had been doing so quite a bit. So now let's talk about some specific fractures and dislocations, starting proximally and moving distally. So this fracture is the most common fracture. This end of this bone and this finger, 19% of all fractures are proximal phalanx base, so-called extra-octave fracture, which is either Salter 2 or extraphyseal, like this one. And it's important to check rotation. There's usually abduction displacement as well as some extension, a little bit of which of each can be tolerated because of the remodeling potential and a movement at the MP joint, but rotation does not remodel. It's typically a good idea to reduce these though, and they're usually pretty easy to reduce. Use your thumb as a fulcrum, not a pencil. It's out there, but a pencil can crush a digital nerve and lead to a digital nerve neuropraxia, and you don't want that. And so these are typically pretty stable once they're reduced, and you can put them into a cast, putty tape, and cast them, and then they'll heal quite nicely. However, the same fracture in a skeletally mature teenager is a very different animal. It's usually a little bit of a higher energy injury, a little bit more displaced, and there's no remodeling either in the sagittal or the coronal plane because there's no growth left. And take a look at this cast, which is a beautiful 90-degree flexion intrinsic plus cast that you're probably pretty proud of putting on, but when you look at the MP joint, it's only flexed 45 degrees and the fracture is actually extended about 60 degrees. And this amount of extension is not tolerable because as you try to flex your fingers, that you use up all the flexion at the MP joint and the finger's still sticking up. It's what's called a pseudo-claw deformity, and that's a very difficult problem to deal with later. And so these are much better to reduce and pin if they're at all displaced. Again, different age groups, same fracture, very different treatment. Another phalangeal base fracture, an interarticular version, most often in the thumb, where it's called a pediatric skier's thumb, if you like, equivalent to an ulnar collateral ligament injury. The freshly closed physis still has a little bit of a ring around the edge, which creates a notch and a stress riser that allows a fracture to happen more commonly than a ligament rupture. And if this fracture is truly non-displaced, meaning the outline of the bone is perfect, you just see a crack, then that can be put in a cast. But if it's displaced at all, it's a rotational displacement where the ligament at this end of the fragment is pulling proximally. That needs to be fixed because that will just continue to rotate as the ligament shortens. And so it's my preference to fix these, and if it's displaced or mal-rotated at all, and so that is either an open or closed reduction with K-wires. You can use a variety of other fixation devices if you like. Then there's this phalangeal base avulsion fracture, which is the volar plate avulsion fracture. Here, you don't need the bone to heal because the volar plate will heal around it quite nicely with scar tissue. The trouble is that scar will make the PIP joint hopelessly stiff if you lock it up too long, especially if you immobilize it in flexion. So the opposite is true here, where you want active motion. Now, you have to be aware of the zebra, which is a shear type fracture, often a Salter 4. This is pretty rare, but you can see here there's a loss of congruity of the PIP joint. This needs to be fixed. And then on the other side of the middle phalanx is where the central slip inserts. So with a fracture here, you really want this fracture to heal. You don't want this fracture to displace. Now, when you have both of these, it's probably just an impaction fracture of the rim against the dorsal part of the phalangeal neck, the proximal phalanx neck from hyperextension rather than a pure avulsion injury of the central slip. But this still will put in a splint for a couple of weeks, get it to start to heal before then moving it to prevent stiffness from the volar plate fracture. So different sides of the bone, different treatment. Into the phalangeal shaft, these are usually in older children and they're often spiral fractures. If they're non-displaced, they're quite stable, but if they are displaced at all, they tend to be very unstable because of the pull of the various tendons and the obliquity of the fracture, and so closed reduction and pinning is my preference here. You can open these and put screws in, but that's typically not required. And then the phalangeal neck fracture, the classic pediatric finger fracture, almost unique to children. This is the so-called supracondylar humerus fracture of the finger. You flip this around in your mind, it looks just like a type 2 supracondylar fracture. This is a type 2 phalangeal neck fracture, so it makes sense that this anterior spike would be a block deflection and that the coronal deformity would not remodel because of the lack of coronal motion at the adjacent joint. There can be some remodeling in the sagittal plane. This is a child that took 2 years to get this amount of remodeling, but it's very slow because it's at the opposite end from where the main physis is, and I would argue that it really only occurs substantially in the sagittal plane and certainly not rotational like this one is. And so an anatomic reduction is important. It's also unstable, and if you do reduce it and put into a cast to try closed treatment, you can't assess redisplacement in the cast because you have multiple fingers in the cast at the same time, and you can't see if it's redisplaced unless you take the cast off. And so generally pinning is the preferred treatment for these fractures if they're displaced. And it helps to hurry to get these done because often these will present late. They thought it was just jammed is the line you typically hear. And so they'll often present already with callus as an incipient malunion. And you can get up to 30% risk of AVN of the condyles from an open reduction beyond 3 weeks. And so my preference here is a percutaneous reduction, a percutaneous osteoclasis and joystick reduction, which you can do up to 3 to 4 weeks. And then there's the phalangeal condyle fracture, which is sort of like the lateral condyle humerus fracture. And all of the bad things that can happen to lateral condyle humerus fractures can also occur in these fractures, such as slow healing, late displacement, and even non-union. And so this fracture, even though you would measure this to be under 2 millimeters of displacement, the joint is not congruent on this side, and this is just going to continue to slide. And so this one I would also argue needs to be fixed. It's much easier to do that percutaneously than it is to have to take it back later and open reduce it and fix it with pins or screws later. And it's even more problematic to have it heal as a malunion because of the clinical deformity and a loss of congruity of the joint, which leads to stiffness and also arthrosis. And although you can do a condylar advancement osteotomy through here and slide this up, that only corrects the coronal deformity, but it doesn't improve articular congruity substantially. And then there's the Seymour fracture, which is, again, almost uniquely pediatric. It's usually a physeal fracture or sometimes juxtaphyseal fracture or a Salter 2 that is open. And it's open because the proximal end of the nail was pulled out of the epinicial fold. Note there is no subungual hematoma. Anyone who's taken a nail off knows that it takes a fair bit of pressure to dissect underneath the nail. So if the blood has an easier way out, such as around the base of the nail, it will not be able to generate the pressure required to create a subungual hematoma. If you don't see a subungual hematoma, be concerned that this is a Seymour fracture. So take the nail off, and you'll be able to look right down into the physis. And you'll see there's typically a flap of nail bed that's interposed into the physis. This is physeal cartilage that you're looking at here. And so that once the nail is removed, you need to irrigate it, reduce the fracture. I typically don't repair the nail bed anymore. I used to, but now I worry that because the injury is so proximal that you can cause more damage putting sutures into the germinal matrix, and so I no longer make these back cuts as well. And typically once the fracture is reduced, the nail bed is then stabilized quite well, although sometimes the fracture is unstable enough that it needs to be pinned. But you also have to be aware of what I call the stealth Seymour fracture, where the nail gets pulled out but then goes back under the epinicial fold instead of sitting on top of the epinicial fold. All that's left behind is bleeding around the cuticle. You don't see a subungual hematoma again, but this one unfortunately is full of pus because it took 4 different hospitals for someone to recognize that this was indeed a Seymour fracture. And when you have an infection there, that needs to be washed out, and then often the fracture is unstable enough that it needs to be pinned. And although they get osteomyelitis, that's easily treated, and the deformity of the nail is pretty mild, but they end up with a growth arrest that is the most common permanent deformity here. And if it's a young child on the middle finger, then that can cause a clinical deformity in the lengths of the fingers. Then the mallet fracture is if it's a mallet finger, a soft tissue injury, and I know we're going to hear more about tendons from Scott later, but typically a splint can work in older children, or sometimes pinning the finger and putting a cast on in the much younger children in whom splint wear is not either reliable or a good fit. But if it's a bony injury, a mallet fracture, then typically these also can heal quite well if the joint is congruent. But if the joint is incongruent, I typically recommend close reduction and pinning using an extension block technique shown here. However, that only typically works up to 2 or maybe 3 weeks out from the injury. You don't get much movement thereafter. And so late open reduction is fraught with perils of soft tissue complications and nail bed injury and whatnot. And so typically, if they're acute injuries, I will recommend close reduction and pinning. And if they're chronic injuries, I typically treat them symptomatically. And then lastly, the tuft fracture is usually a crush or laceration mechanism. And so the fracture itself is usually insignificant, and it's a soft tissue injury that's dictating the care. And just a quick word about fingertip injuries, just because I see this all the time, where people have put the nail plate back on top of the epinicial fold and then sutured the germinal matrix shut quite nicely here. That drives me nuts because that's just creating a syncytium. And so this is the #1 reason to have to take a child back to the operating room, in fact, to put the nail back under the epinicial fold to prevent a syncytium formation. So always repair the nail bed with absorbable sutures and then replace the nail or foil under the epinicium. And then finally, just a word about dislocations. Metacarpal phalangeal dislocations are more common in children than they are in adults, and they're more common in young children than are PIP dislocations. There are 2 types, simple and complex, based on whether or not they can be reduced. It's very, very important, though, if you have what you think is a simple dislocation, not to pull traction on the thumb when you're reducing it, because doing so will take a volar plate that's draped around the head of the metacarpal, create a vacuum in the joint, and suck the volar plate up into the joint, blocking the reduction then. And so if that's the case, you can sometimes flush the volar plate out with an injection of some local anesthetic into the joint. That's happened in my hands once. But hey, I had a camera, so that looks neat. But otherwise, it's an open reduction that's required. And I would argue, even though this isn't in any textbook anywhere, the timing of when you have to do this, you can see tenting of the skin, pressure on neurovascular bundles, especially in the index finger, And so I would argue that if you can't reduce it in the ED, this is something that goes to the OR that night, or at the very least first thing in the morning for a reduction. And then PIP dislocations, pull all you want. The most important thing with PIP dislocations is to document the direction of dislocation, because the dorsal dislocation, which is by far the most common, will rupture the volar plate, and early motion, if stability allows, is the appropriate treatment. And whereas a volar dislocation or palmar dislocation will avulse the central slip, and that needs to be splinted and extension until the central slip heals, anywhere from 4 to 6 weeks, to prevent a boutonniere deformity. So exact opposite direction, exact opposite treatment. And sometimes someone's pulled on it already on the football field or in the ED before getting x-rays, and you have to resort to the picture on grandma's cell phone to get an idea of which direction the dislocation was, but that's an important investigation to do. So a few take-home points from this whirlwind tour: a thorough evaluation of these injuries is essential, using physical exam tricks and dedicated x-rays of each injured finger. Be careful of the risks and problems that can occur with splinting and casting, and then beware of the seemingly minor finger injuries, and so that you can recognize and provide prompt treatment of those problem fractures. So thank you very much for your attention, and I think we will move on next to metacarpal fractures. And there's a Q&A button down there that you can click on to submit questions, and I'll be around for the rest of the talk, so we can go over them in that session. So thank you.
Great. Thanks, Roger. Christine?
Yep. Can you hear me, Josh?
Yes.
Great. All right. So this will be pediatric metacarpal fractures, no disclosures. And so a little bit about radiographic anatomy of the pediatric hand, especially looking at metacarpal. So your physis is going to be at your neck for the 2nd through the 5th rays. Now that's different for your 1st ray, where the physis is actually at the base. And obviously this has implications for the amount of remodeling potential. And it's really quite profound when the physes are open. As far as metacarpal fractures themselves are concerned, many of these are adolescents who are getting into fights, very similar to the adult population. And so a lot of the times you do have these repeat offenders that you'll see that keep coming in because they cannot control their temper. And for me, especially if it's one that's operative, I really have a talk with the family and the patient that, listen, I'll fix these 3 metacarpal shaft fractures that are in all different directions. But if you go out and you hit something else and you refracture and end up needing surgery again, you're going to have to find another hand surgeon, because I'm only going to do this once. And so I've either gotten through because I haven't had to do a repeat, or maybe I scared them and they're going somewhere else. So a little bit about the exam. You always want to check the angular displacement, especially in the coronal plane, the amount of shortening, because if it's too short, you may have a functional problem, especially in the more radial rays, and of course the rotation. And you also want to check the extensor lag. So this is a child that came in 3 to 4 weeks after having their injury and really doesn't look that bad. But when she makes a fist, you can see there's profound scissoring, and this was something that could have been treated with just a derotation maneuver and a well-placed cast. So metacarpal shaft fractures, most of these are isolated and stable fractures. We attempt to cast these out with a well-molded cast if there's no extensor lag or scissoring on the exam. If there is an extensor lag, especially if it's a single metacarpal, oftentimes we do try to, in fact, I would say the majority of time we try to mold these out in clinic, so that way we can get an acceptable amount of extension. No matter what, though, they will always have a little bit of a dorsal bump. And so you can see that this is that same patient right here. And it is amazing with the amount of angulation that is in this skeletally mature patient. They have complete full extension with no extensor lag. So if the family is fine with that dorsal bump, there's really no need to do anything else other than put this in a cast and mold it to make sure it doesn't drift. Multiple fractures or unstable fractures often need fixation, and typically a more adult pattern. So here's a patient here that got molded and casted, lost reduction, discussion with the family, and ended up getting a pin. So check the rotation, even though the kid may come in and be quite painful and have difficulty with trying to get that full composite fist to test for scissoring. If you look really carefully at your radiographic appearance, you can really see that with the condyles. And so it's obvious this child's got multiple metacarpal fractures. And if you look at these condyles, they're facing the same way, but that third one doesn't really look the way it's supposed to. And the second looks a little different from the rest of these. And so when you kind of blow these up, you can see that there's a malrotation, and that's what I would expect prior prior to going in there. So in addition to having the kid gently flex their hand, looking at all of the condyles and profile can really help you with identifying that. Pretty rare to have to fix metacarpal injuries in this age group, but this is a child that got their hand crushed by a foosball table, and the foosball table won. And you can see widely displaced, lots of soft tissue swelling, and this kid ended up having compartment syndrome, and so this child went for fasciotomies and pinnings with a large hematoma evacuated. And even though a lot of times we say, well, they're just kids, just stick it in a cast in the same room, they're going to heal. Two, I believe, of these metacarpals ended up going on to non-union and ended up being plates down the road. So metacarpal neck fractures, these have a very high remodeling potential, especially in the small finger, which is known as the boxer's fracture, which I'm sure all of you are well familiar with adult patients. And so what's acceptable? Well, they do state that in adults, the number that's bandied around is 60 degrees of angulation. So for kids, if their physes are open, you could probably accept, I mean, I don't want to say almost anything, but probably almost anything. However, again, you do want to check for an extensor lag. To reduce these, you flex the metacarpal phalangeal joint to 90 degrees to loosen the collateral ligaments and use the proximal phalanx to push up on the metacarpal head. There have been, I was traditionally taught that these need to be casted in intrinsic plus to help push on that. There's been a couple of other studies that say casting in extension is fine. I think the important thing is whichever way you cast it, you have to make sure that you've got a force on that head to try to prevent it from having apex dorsal angulation. And it is pretty rare to need operative intervention. I think I've only done one of these that was a single metacarpal neck fracture in the over 13 years, almost 14 years that I've been in practice. And that was one that was so far displaced that the head was actually down in the palm. And again, you want to tell the families about that dorsal bump. And so you tell them ahead of time and they expect it as opposed to later when it suddenly becomes an excuse and you're kind of backpedaling and they all think it's the knuckles. So just, I always tell them ahead of time, there's going to be a dorsal bump. There's not a lot of muscle over the dorsum of the hand. And so any sort of callus or prominence is always very easily seen. So this is a 17-year-old male. You can see he's a repeat offender, status post-fight. You can see prior deformity to that fifth metacarpal. So this is not his first rodeo. And what we're looking at now is the second metacarpal neck, really minimally displaced looking at this AP, but you look at this lateral and you can see that it's about 45 degrees angulated. And he does have clinical deformity with an inability to fully extend that second metacarpal. And so that child got a pin to correct that and to allow him to have full extension of his finger. Metacarpal head fractures, these are intra-articular fractures. In the skeletal image, sure, they do represent a Salter-Harris 3 fracture, so they do have a high risk of physeal arrest. Luckily, most of these are in adolescents, such as in this patient, so you don't necessarily have to worry about it. A CT scan can be really useful, such as in this patient here, where I saw that fragment, and I said, well, where is it? It looks like it's volar, but where the heck is the donor site? And so we get a CT scan, and it actually shows that despite the fragment being volar, the donor site is actually dorsal, and so there might have been some degree of dislocation, relocation in this one. This is a 9-year-old male who punched something, and again, you can get that CT scan, which is can really be helpful to kind of show what that physis looks like, how you're going to approach this. And so we end up doing an X-fix to try to distract that joint, as well as I think there were some perk pins in there to restore that joint at some point in time. But despite all of that, you can see he ended up getting physeal arrest and had a little bit of central avascular necrosis that was painless, and we just watched. So metacarpal base fractures, always look at the true lateral to look at your carpal-metacarpal congruity. And for intra-articular extension, I have a really low threshold for a CT scan. I get a CT if I know I'm going to fix it, and I get a CT if I think I'm not going to fix it, to prove to myself that this is not one that needs to be fixed. So you can see the lateral here, and there's obvious disruption, although it looks quite benign and like a single fourth metacarpal base fracture on the AP. And again, here's that CT scan, which I think just really helps you with your planning, showing how many pieces there are, what the state of the handmade is, and how much you need to elevate that joint. And so this is what that patient ended up getting. A little bit about carpal-metacarpal fracture dislocations, because they are easily missed. And again, I find the CT scans to be essential for surgical planning, usually in conjunction with hamate fractures. And so you can see, even though it looks pretty benign on the AP, on the lateral, you can see that that's clearly not lined up the way it's supposed to. And again, with the CT scan, kind of a similar story to the other child. You can see that the carpometacarpal joint is disrupted, and it's really a carpal fracture with subluxation of the metacarpal bases. And so this got this. And so a little about thumb metacarpal fractures. Typically, they are at the base of the metacarpal, and many times they are extraphyseal. Now, the good thing is that their physis is at the base of the metacarpal, like we showed here, and there's high remodeling potential. And so because of that saddle joint that has universal motion, the thumb, when skeletally mature, can reach about 50 square centimeters of surface area. So that really helps you with the fact that you can get away with quite a bit of deformity. This is a X-ray from Rockwood and Wilkins. I don't have an example that's quite as profound and impressive as this. And so you can see here's the fracture, probably about 60 degrees angulated. I often get called because they think it's a Bennett's, but it's not a Bennett's. As you can see, here's the epiphysis. This is the physis. This is extraphyseal. So this is not a Bennett's fracture. This is an extraarticular thumb metacarpal fracture. And here the child is at healing, and here the child is with absolutely 100% profound remodeling. Now, the Salter-Harris 2 fractures, when they're very widely displaced, they can be unstable because of soft tissue or periosteum being intersposed. Now, Salter-Harris 3 fractures are rare. This is this type D fracture here, and that is the pediatric equivalent to a Bennett's fracture. Those do require ORIF, both to get the joint congruous as well as to get the physis lined back up. And again, like any Salter-Harris 3 fracture, they do have a high risk of physeal arrest. The other one that you need to know about is the type C fracture. And so on this schematic, this is a right hand. So you're looking at a right thumb metacarpal with the rest of the rays over here. And so here's the type C Salter-Harris 2 thumb metacarpal fracture. And so these are really unstable. You can see the shaft is translocated ulnarly, and that's because of the really, really strong pull of those adductors. It's extended and it's shortened because of the pull of the abductor pollicis brevis. But the resident really did a great job, and it looks, pretty anatomic, looks really good. The problem is it's really hard to mold when you've got all those thenars in the way. And so 1 week out from the reduction, it drifted and got a pin. And so there the child is at healing. And so the little take-home points for metacarpals is that the vast majority of these can be managed non-operatively. You do need to carefully examine the patient to evaluate any sort of extensor lag or malrotation or scissoring that might be present. And don't miss carpometacarpal fracture dislocations. Get a good true lateral and get a CT scan if you have any doubt or questions. And there are some thumb metacarpal fractures that do need surgery. The Salter-Harris 3, which is the pediatric Bennett's fracture dislocation equivalent, and those where the type C's where the shaft is only displaced, those are unstable and those need to be pinned. Thank you.
Great. Thank you very much, Christine. So we're going to continue moving proximally, and we'll go to the carpus, where Don Bay from Boston Children's will focus on the scaphoid fractures.
Thanks very much, Josh. Sarah, if you could give a nod or a thumbs up if you can hear me and see my slides.
You're good.
Thank you very much. I appreciate the opportunity to be here with everybody. Thank you all for your valuable time. My charge is to talk a little bit about scaphoid fractures. I have no disclosures. However, Roger mentioned a Hand Society textbook that he edited that's coming out on pediatric hand conditions. I want to acknowledge that a lot of this information will be available in that text in the chapter written by Jessica Hanley from the Medical College of Wisconsin. So my objectives will be to briefly talk about the pertinent anatomy and development of the scaphoid. We'll talk about the clinical evaluation of scaphoid fractures in children and adolescents. And we'll touch on some injury patterns and treatment principles, both for acute scaphoid fractures as well as chronic non-unions. It's an appropriate topic for a pediatric webinar, though we understand that the incidence is about 1 or 2 in 100,000 people per year. The peak incidence is in the adolescent or teenage age group, the folks that we all see in our practices every day and every week. Anatomically, we all know that the scaphoid serves as the important biomechanical link between the proximal and distal carpal rows, because more than 80% of the surface area is covered by articular cartilage. The blood supply is quite limited, and for the most part comes in through the dorsal ridge vessels, as well as the vessel to the distal pole. In terms of its development, the scaphoid typically arises from a single ossification center, which becomes radiographically apparent at the age of 4 or 5 in boys and girls. And this ossification from distal to proximal probably explains the variations in the fracture patterns we see, which historically have been described as being distal pole fractures only. And although controversial, there is an entity out there called the bipartite scaphoid, thought to be a congenital variant with a very characteristic radiographic appearance as shown here, oftentimes bilateral in patients who are typically not very symptomatic and do not report a history of trauma. I think we're all familiar with the clinical presentation. These patients come either with a lot or very subtle radial-sided wrist pain after a fall. It's really imperative, particularly in kids and teenagers, that we have a very focused examination looking for tenderness in the snuff box and on the tubercle, and trying to elicit symptoms with both axial load and compression. And we know from prior studies that while each of these tests and examination maneuvers individually are very sensitive, really it's the constellation or using all the clinical tools in our toolbox that give us the best sensitivity and specificity. Now, historically, scaphoid fractures in kids and adolescents were thought to affect the distal pole only, requiring neither surgical care or any kind of long-term follow-up. Van Vanen and others reported in the 1980 a series of over 100 pediatric scaphoid fractures. Over 85% were of the distal pole, and all did fine with casting. And there are other studies that convey a similar message. But as Roger and Christine both nicely stated, the kids we take care of are really changing. They're bigger, they're involved in more extreme activities at a younger and younger age. And this has resulted in a shift in some of the injury patterns we're starting to see in our younger and younger patients. We previously did a study of over 350 scaphoid fractures at our institution. The average age in this series was about 14 and a half years. And in our series, looking at a more contemporary number of pediatric scaphoid fractures, we found that the vast majority, over 70% of scaphoid fractures, affected the scaphoid waist, not the distal pole. And even when we looked at patients with open physes who were still growing, over 2/3 had waist fractures, suggesting that our kids and adolescents now are getting fracture patterns that are much more similar to their adult counterparts. We did some logistic regression analysis to look at the success rate or likelihood of bony healing with casting alone. And not surprisingly, in acute fractures that were non-displaced, say of the distal pole, the healing rates were almost universal. Similarly, for non-displaced waist fractures, the healing rates with casting alone were very high, greater than 90%. But once we got into displaced injuries, for example, in the scaphoid waist, we found that the healing rates precipitously declined with casting alone. And so similar to adult treatment principles, now for the pediatric scaphoid, the non-displaced fracture, I'd submit, is successfully treated with casting, and surgical reduction and fixation should be reserved for displaced fractures acutely and those of the proximal pole. So here's a case example, 13-year-old male, you can see the open physes, a non-displaced scaphoid waist fracture, treated in a short arm thumb spica cast, ultimately with a very good clinical and radiographic result. I realize that in the adult world, there's increasing enthusiasm for percutaneous or in situ screw fixation, even of the acute non-displaced fractures. And there's plenty of literature suggesting this results in faster healing and perhaps earlier return to work or military duty. I think we're all familiar with the surgical techniques. Our preference is to do this through a small dorsal approach with positioning of a guide pin and using a cannulated system, achieving center-center positioning of the screw as demonstrated in these fluoroscopic images. But I would also submit that percutaneous or in situ fixation is not benign, and there are some studies early in the experience that have suggested complication rates approaching 20 or 30%, including persistent non-union, troubles with the implants, or even adjacent soft tissue injury. And when we looked at our series that we previously published, we found that one of the risk factors independently of longer times to healing after surgery was the present open physes. So I'm not sure that the adult information can be clearly and adequately applied to children and adolescents in this regard. Proximal pole fractures, however, are a different beast, and we would continue to recommend surgical reduction and fixation of proximal pole fractures acutely owing to the limited vascularity. The real concerns about persistent non-union and the challenging salvages if a non-union does occur. In many series, including ours, and I think in a lot of your practices as well, particularly in the adolescent age group, we see a lot of chronic non-unions. Perhaps 20 or 30% of the scaphoids that walk in the door are presenting late. And the treatment considerations are the same as in adults. We have to think and be mindful of the location of the injury, whether there's associated deformity or not, and what implications on the vascularity of the proximal pole there are. And the options or the surgical tools include open reduction and internal fixation, with or without bone grafting, and that bone grafting can be vascular or non-vascular. Just some case examples, here's a typical scaphoid non-union. We can see some comminution and cystic changes in addition to the characteristic humpback type deformity on the image on the right. This patient was treated with traditional open reduction, bone grafting, in this case using a tricortical iliac crest graft as shown here, with a nice clinical and radiographic result after stable internal fixation. But there can be other tools that we can apply from the adult world to our younger patients as well. This is a 15-year-old male with 2 years of wrist pain. Radiographs demonstrate a proximal pole non-union, and subsequent MRI demonstrated concerns about vascularity as well as cystic changes. In this particular patient, this was treated with an open reduction and a vascularized pedicle bone graft with screw fixation, and fortunately went on to a nice clinical and radiographic result. And occasionally we'll see some real problematic salvage situations, such as this 17-year-old male with persistent wrist pain 2 years after a prior scaphoid operation. I think the plain radiographs clearly demonstrate implant migration and persistent non-union. Subsequent three-dimensional imaging raised concern for deformity and loss of the bone stock there. In this particular situation, due to the need to correct deformity and provide vascularity, a pedicle bone graft was utilized from the volar part of the distal radius. Pins were used instead of screws owing to the limited bone stock available, and thankfully this patient went on to clinical and radiographic healing. We did a follow-up study at our institution looking at 63 patients treated for scaphoid fractures both acutely and after chronic non-unions with a mean follow-up time of 7 years. And thankfully, with appropriate and timely treatment, we were able to get and hear about good patient-centered outcomes. DASH scores for both acute and chronic patients were very favorable compared to published population norms. And even sports and art subscores were very good, though there was indeed a trend for patients presenting with chronic non-unions to fare a little bit worse. But ultimately, our treatments can be really helpful in this young, active patient population. So in summary, I would submit that scaphoid fractures are common in teenagers and the injury patterns are now similar to adults. We would continue to advocate casting for the acute non-displaced fractures of the waist. And we should keep in mind surgical treatment options for acute displaced waist fractures, proximal pole fractures, be they acute or chronic, and established non-unions. Thank you for your attention.
Great. Thank you very much, Don. So I'm going to move on to talk about distal radius fractures. Hopefully you guys can see my screen PowerPoint now and not a Word document. I have no disclosures pertaining to this other than some book chapters and books pertaining to some of these topics. So distal radius fractures in children and adolescents are extremely common, accounting for 30 to 50% of all pediatric and adolescent fractures. For the most part, they're easy to treat, predictable, and have excellent outcomes, but they can be difficult if they don't follow the rules. We classify them, as we know, physeal fractures utilizing the Salter-Harris classification, with Salter-Harris 2 fractures being the most common. As we progress up the classification to Salter-Harris 3 and 4 and 5 fractures, we have a higher risk of growth arrest, and we'll talk a little bit about more of that. And then we can also classify distal radius fractures extraphyseal. When we talk about them as extraphyseal, we're really utilizing descriptive terms such as green stick, a torus fracture, buccal fracture, or bicortical metaphyseal fractures. I think we're all familiar with buccal fractures. These are cortical failures due to compression that occur in the metaphysis. These are uniformly stable by definition. However, we do need to be wary of the buccal fracture. It's a little bit more, and it's really a bicortical metaphyseal fracture that can displace. But a true buccal fracture has no need for reduction. These can be treated with a splint that the patient self-removes once their pain resolves, or some people still treat them in a cast for about 3 weeks, and then you can take it off to ensure the child's pain is resolved. Bicortical metaphyseal fractures, the majority are dorsally angulated due to a fallen and outstretched hand. There is a trend towards higher energy mechanisms among younger patients, such as sports and ATV use, just as in the scaphoid fractures that Don talked about. The vast majority of these fractures can be treated with closed reduction and casting, as you see here. Excellent results. The reduction is very similar to what we would do in an adult, where we recreate the deformity, apply longitudinal traction, and then vorally translate the carpus without excessive flexion of the wrist. However, we must recognize that 1/3 of fractures that need to be reduced will redisplace over time. Here's a 9-year-old who fell off a swing that has this dorsally angulated fracture, underwent a gentle closed reduction and casting, and here it is 1 week later with loss of alignment. And we can understand and know that casting adequately is really the most important predictor with regard to loss of reduction. Whether you utilize an intraosseous mold or a 3-point mold, either one is acceptable, but certainly some molding needs to be performed, as you see depicted in these pictures on the bottom. The acceptable parameters for distal radius fractures vary based off of age. There's a lot of remodeling potential due to the fact that these fractures are near the distal radius physis, which accounts for 80% of longitudinal growth. As one approaches skeletal maturity, the numbers decrease and become more aligned with adult parameters. These are the predictors of loss of reduction. You can see them listed here. The most important ones being severe initial displacement, as well as an associated ulnar fracture at the same level. But the main one in our control is the casting technique. So it's imperative that we have good casting technique with a good cast index of greater than 0.7 to try and maintain that reduction in the cast. Not only do we need to have a good initial reduction and a good cast, but we need to follow the fracture to make sure displacement does not occur. So in my practice, we obtain weekly radiographs for at least 2 weeks to ensure that the fracture does not redisplace over time, and if it does, we can address it in a timely manner. I think everyone on the panel would agree with me that the art of our job is understanding what will remodel and what will not, and therefore that will determine whether or not we need to proceed to the operating room if we have a loss of a reduction. So the remodeling considerations are dependent on the number of years of growth remaining, how close it is to the physis. We discussed the distal radius, accounting for 80% of longitudinal growth of the radius, how much angular deformity is present, and the plane of angulation relative to the nearby joints. Remember, fractures closer to the physis and angulated in a plane of joint motion have the greatest remodeling potential. Here's just an example out of an old textbook that shows substantial displacement in the young child, and over time we can see that this can completely remodel. And here's my 9-year-old case of a child who fell off a bunk bed. Here we can see initially good reduction in casting. However, 2 weeks later, there is some displacement. I think we all recognize this portion of the cast was probably suboptimal, allowing for that radial deviation at the fracture fragment. I do not think that required any operative intervention, and certainly this remodeled adequately over time. So can we truly predict what's going to remodel? There are a couple articles out there that have tried to do this retrospectively. Nothing has been able to have a good, adequate formula for us to utilize clinically, as these are not practical in nature. So I've developed this algorithm for us to follow through. If we find a fracture that does displace over time following a reduction. So the first thing we would do, as we talked about, would be repeat attempt closed reduction, typically in the operating room, and then stabilize the fracture with percutaneous pins. This is the operating room setup I utilize with the fluoroscopy inverted. Again, we're going to do our reduction maneuver of longitudinal traction, flexion, and volar translation on the carpus to reduce that fracture. And I utilize the semi-sterile technique, which we've popularized to limit amount of waste in the operating room and hopefully save some time. But the semi-sterile technique can be utilized in these cases as well. And then your pin insertion, I think we all recognize this is fairly straightforward. Percutaneously start at the level of the radiostyloid for physeal fractures and just proximal to the level of the physis for extraphyseal fractures to avoid crossing the physis if possible. And then you can bend and cut your K-wire. And then you can place your well-molded cast and remove your pin in the office at 4 weeks. So what if you can't acutely reduce the fracture in the operating room? Well, then we go to the osteoclasis that Roger talked about earlier for phalangeal neck fractures. So here we are, a 4-year-old who fell off a swing, was in a long arm cast, and 11 days post-injury was certainly headed in a poor direction. I think we can argue that this certainly could have remodeled, but we don't know if it would have worsened over time. And after discussion with the parents, they wanted it fixed. And this went to the operating room. Attempt at closed reduction was performed. There was already too much healing for a gentle manipulation to be successful, and the gentle osteoclasis was performed. And then we could obtain acceptable alignment. It's not perfect, but certainly acceptable now and stabilized. So this has been studied. Here you can see results of caloclasis or osteoclasis of distal radius fractures. They had 21 patients in this study, all of which had excellent results with less than 2 degrees of angulation at final follow-up without any complications. So a very useful technique in your armamentarium. So as we progress down the algorithm I showed, here's a 15-year-old who had hurt his wrist 4 weeks ago and re-injured it when he was arrested. Attempt at reduction was performed in the emergency department. There was no movement at the fracture. I think we would all agree that this is not acceptable alignment for a 15-year-old child. This is a Salter-Harris 2 physeal fracture that more likely than not will lead to physeal arrest when we address this. So we could consider a full osteotomy, but in these children in these acute, semi-acute settings, we've gone to utilizing a mini approach. And in this case, we just did a mini dorsal approach. We were able to break up the fracture healing with a Steinman pin and small osteotome and reduce it into acceptable alignment without the need for formal plate and screw fixation in this child. At the same time, because we predicted the distal radius physeal arrest, we performed distal ulnar epiphysiodesis to prevent any chance of ulnar abutment syndrome. And then here's a 13-year-old female who fell off a horse. Initial reduction is adequate, but over time, starting to lose reduction into unacceptable parameters. 13-year-old female likely be reaching skeletal maturity. And if we follow the algorithm, osteoclasis, probably unsuccessful. And this is a metaphyseal fracture. So this would receive a formal open reduction and internal fixation to stabilize that fracture. And lastly, I'll end with this 14-year-old who was in an ATV accident and 3 weeks post-injury had volar angulation this time, and this again would require a formal ORIF to address that. So these fractures can go on to complications. We've discussed loss of reduction, which can occur in 10 to 90% of them. We've discussed physeal arrest. There's a condition called supination dissociation, which I'll run through with you. Obviously, they can go on to malunion. Non-unions are rare, but can occur. The most common complication is a pin tract infection, as you see depicted there. And we should just be aware of all of these. So supination dissociation is malalignment of the DRUJ. Typically, these are fractures that are mildly dorsally angulated. And what you can see happens, hopefully you can see my mouse, over time, as a child grows, you get an extension deformity more proximally in the radius, and this leads to malalignment of the DRUJ and loss of supination. So here's a case example of a 15-year-old that was wrestling. When the friend jumped on his wrist, he had this mildly dorsally fracture of only about 20 degrees. This was treated in a cast. Really, the post-reduction didn't change the alignment. This was allowed to heal with a persistent dorsal angulation. And over time, the fracture went on to unite. However, this dorsal angulation migrated proximally, and the child presented with complaints of loss of form rotation, only 30 degrees of supination compared to 80 degrees on the uninjured side. And you can see the slight dorsal angulation, the slight malalignment of the DRUJ with the distal ulna, mild dorsal. And this went on to have a volar correcting osteotomy to correct dorsal tilt, and that restored supination, at least into acceptable parameters. And as we talked about, physeal arrest can occur in 1 to 9% of children. These can occur even in non-displaced fractures, but the risk is much higher in displaced physeal fractures. And remember that any fracture involving the distal ulna has up to a 50% associated risk of physeal arrest, as you depicted here. Risk factors include multiple reduction attempts and late reduction attempts, including attempts more than 10 to 14 days from the time of injury. And these are typically treated with distal ulnar epiphysiodesis, as I showed in the other case, as well as an ulnar shortening osteotomy if the patient is ulnar positive, as is the case here. And here's an 11-year-old female case example, fell off the monkey bars and had this fracture, underwent nice reduction. I think we'd all be happy with that. 1 week follow-up maintained at 2 weeks, 2 months follow-up, advised to just come back if there are any problems. And here's a child 2 years later with that distal ulna physeal arrest. And certainly, as I said, really want to try and avoid any physeal injury caused by us. So we don't want any repeat reduction attempts or late attempts at reduction beyond 10 to 14 days. You want to optimize your chances with adequate sedation, plus or minus mini fluoroscopy. There are some studies that say it's helpful, some that say it's not. And here I'll end with this case of a malunion physeal arrest that presented 7 years after the original injury, complaining of deformity and pain. And this is why really 6 months after the original injury, you should see these children back till you can make sure that this is working and they're not developing physeal arrest. And this child had these original injury films, acceptable alignment, some mild translation present on the lateral view as well as the coronal AP view, but acceptable. And 7 years later, we can see the substantial ulnar deformity, ulnar positivity with loss of the radial inclination. And this certainly was addressed in the operating room with a iliac crest bone graft. Not perfect result, but better for this child. So remember to avoid accepting unacceptable reduction. Do not perform multiple or late reduction attempts, as that'll lead to a physeal arrest. Make sure your cast technique is optimal, and make sure you follow these children up with repeat radiographs 6 months or even a year later to ensure that the physeal is working. Remember also that a risk fraction of preteen can become a form deformity, leading to that supination dissociation that we mentioned. Keep families informed of the risk of loss of reduction and physeal arrest, and bring these patients back for the repeat x-rays. Thank you very much. So I'm going to turn things over to Dr. Herman, Marty Herman from St. Christopher's Hospital for Children, who's going to talk about forearm fractures. Then you got to go up to your first slide, Marty. Go exit out again. Or you're on mute. On the left side, go to your first slide of your talk. You're on slide 7.
Can you hear me now, Josh?
Yes, we hear you now. And I think you're still on slide 27. There you go.
Better now.
Okay.
Can you see that, Josh?
Yes, we got you.
Okay, great. All right, let me go back because I am way back. Let me just flip back. There we go. Okay. So pediatric forearm fractures turn out to be ideal for asking questions on tests. So I'm going to go through this with the idea that each slide will have some pearls that might appear on a test, because while it's a very complicated topic, there's a couple interesting points that probably every single pediatric orthopedic surgeon is aware of, but every resident should know, because the people who are writing the tests want you to know them. So these are diaphyseal fractures of the radius and ulna. They are common, about 3 to 6% of all our fractures, with the peak age of about 10, and the classic boys versus girls. So the outline I'm going to talk about is briefly mechanism of injury, how to assess them, the treatment options, and then the complications that go along with it. So these, as every other injury that we talk about in the upper extremity, are almost all similar in the sense that they are the foosh, the fall on the outstretched hand. Most of these fall into the lower middle energy category. So they're really almost all isolated injuries. And if you look at open fractures, forearm fractures turn out to be a very common open fracture, especially when you're looking at those that occur in the upper extremity. This is the classic fracture where the ER doc says there's a little bit of bleeding, maybe an abrasion, and you squeeze and there's some a little bit of blood that drips out of this abrasion. So here's the history that we just talked about. Physical exam. So some of these are dramatic. There is deformity. And actually, sometimes I used to say when the deformity is fixed, like in this x-ray picture, that implies there's a green stick fracture. And as you go and reduce them, they're actually better. It's the floppy arm that's the more difficult one to reduce. Soft tissue includes looking at the skin, as we just talked about, looking at compartments in terms of swelling. And the neurovascular exam is critical. It turns out this is actually a relatively uncommon standard fracture to have an injury to either the neurostructures or the vascularity, but always beware. So careful exam falls in every single situation. Simple classification system really is based on where the fracture occurs relative to the bone. So proximal, middle, and distal third diaphyseal fractures are the way we tend to describe them. Depending on how the hand was actually loaded, whether the arm was in supination, pronation, or no rotation, sometimes will dictate where the fracture lines are. But if the hand is in supination when the child hits the ground, the ulnar fracture will be distal to the radius. If it's no rotation or relatively high energy, it tends to be across or transverse the same level. And then pronation is the opposite of supination. Very important that the AP and lateral x-rays of the forearm include the elbow and the wrist. So, this is an obvious picture of a Montesia fracture, but if I had cut this fracture somewhere along here, or this was a less displaced injury, then you could argue that this is a relatively easy injury to miss. We're looking for a couple things. So as I said, location. Most are in the middle or distal third, with the majority actually in the distal third. I like to look at whether the fracture is complete or incomplete. So for example, green stick versus not green stick. And some of the ways to separate that out are really basically, is one cortex obviously not broken, but also are the bones not translated relative to each other, and is it just angulated? And then as I mentioned, pay attention that you look both distally and proximally for the potential for the Montesia or the Galeazzi. So I know we love to operate, and all of us love to do surgery on just about anything we can get our hands on. However, remember, just like a lot of pediatric fractures, they start out with closed treatment. So this is no exception. And I know your brain wants to focus on the adult treatments, which is automatic surgery, plate. Well, this is a whole different animal that I want to walk you through. So 90 to 95% of pediatric forearm fractures can be treated with closed reduction and casting. So I cannot stress that enough. So the idea would be plan on treating these in a cast first. Most of us do them under conscious sedation. There are some places that use regional blocks, but the reality of the situation is you need to have a setup really that allows you not only to have the safe conscious sedation, but to apply some sort of reduction maneuver and to apply either a cast or a splint in the ED. And I can tell you from experience, we happen to use casts. It turns out that it doesn't matter if you achieve reduction and are able to stabilize it and fix and hold it with a cast. It's equivalent to a good sugar tongue. It's a matter of preference. Closed reduction techniques, there are several. So if it's a green stick and it's in one of those fixed deformities, you've got to remember that a green stick fracture of the forearm tends to have a rotational component to it. So if the apex of the green stick fracture is volar, then if you pronate the forearm, you will reduce the fracture. The opposite if the apex is dorsal. Complete fractures are a much more difficult problem, as you can imagine, because they're less stable in every single plane. So a couple simple tricks. One is if you don't have finger traps, longitudinal traction and have someone hold the arm up while you apply your cast. Finger traps are helpful for several reasons. One, they allow you to get your length and grossly realign the bones utilizing your soft tissue sleeve, but they also will gently let you achieve a rotational reduction that you would have a hard time doing otherwise. And it's actually some published data to say that they in some ways might be the best way to reduce fractures of the forearm using the finger traps. So casting is critical. This is generally speaking, I will tell you, if it's the middle distal third, I will apply a short arm cast and then run it up the elbow. But if you can do a long arm cast all in one sitting, it probably is better. Now, there's a couple things to remember. Josh pointed out minimal padding. The ulnar border on the forearm fractures should be flat. The elbow should be at 90 degrees and the posterior part of the humerus should be flat. The intraosseous mold will allow for making this cast not round, but oval shaped and push the two bones apart so the interosseous space is out to length or out to tension. So the cast index is something that we all talk about, but somewhere between 0.7 and 0.8 is the ideal cast index that you should measure after you put your cast on. So while everybody wants to focus on the bone, I actually teach that the best thing to do is actually figure out your cast index first. Then you can go back and say, I did a great job. So after you cast, you want to measure angulation, you want to measure rotation. Rotation is either by looking at the cortical diameters, as here, they're obviously not the same cortical diameters. The radial styloid and the bicipital tuberosity point in opposite directions, so sometimes that's helpful as well. So what are acceptable reduction parameters? So you saw Josh's slides about that wrist. There are lots of opinions about how to accept or what's acceptable after you do some of these closed reductions. So this is something that Jack Flynn, who's a friend of mine, always says whenever you see him give this talk. And here's how I like to think about it. Rule of tens. Less than 10, about 20 degrees of angulation is acceptable. Over 10, about 10 degrees of angulation is acceptable. Malrotation is a little bit hard to judge, but basically not a lot. And bayonet apposition is okay if you have at least 2 years of growth remaining. Bad fractures are those in the proximal radius, so I almost will always accept no less than 10 degrees. If the radial bow is straight, or certainly if it's reversed, and if the child is skeletally mature, obviously you're treating them like adults regardless of their chronologic age. Remodeling does happen, and there is a fair amount of compensation that occurs. Josh went through some of the remodeling best ofs, young age, close to physis, acceptable angulation, and sagittal plane deformity. But remember, in the forearm, we most commonly lose pronation and supination, so you use your shoulder or even through your carpus to accommodate. And believe it or not, a fair amount of compensation, almost 30 or 40 degrees, can be made through either one of those two compensation mechanisms. After you cast, you're going to want to see them back. And as Josh said, with their distal radius, very similar, about 7 to 10 days at 3 weeks, and then at healing at 6 weeks. When they lose reduction, you do have an option of re-reducing them with a cast or wedging the cast, but most of us at that point will go to surgery. So operative indications include fractures that fail reduction, open fractures certainly, and fractures in older adolescents who are approaching maturity. Who gets a pin and who gets a rod? So this is a paper that we finally got published after many years, and it's a little bit controversial, but as the elbow olecranon apophysis approaches an adult, and we determine that if you're almost closed or closed, it's probably better just to plate. Now, I know people argue that either are equal, and data suggests either are equal, but in my hands at least, I prefer to use rods when I get the opportunity to. The rods I use are flexible nails. I sometimes will mix flexible nails and K-wires. If I plate, it's a 3.5 or 2.7. Implants. This is the same tray. So remember, the Nancy nails go from 2 to 4 millimeters. When you're going to do forearm fractures, you're going to do the littlest ones up to about 3 millimeters max. You want it big enough to hold your reduction, but you don't want it so big that when you advance it, it actually distracts across the fracture. I prefer personally to use Steinman pins in the ulna. Starting point radius. Good test questions. So there's a dorsal approach, which is right here at the Lister's tubercle. There is a radial approach, which is right here between the first and second compartment. On the test, the EPL is at risk dorsally. The dorsal sensory branch of the radial nerve is at risk radially. Ulna, I prefer tip of olecranon, and I actually just take the Steinman pin and put it right down the pike. It does run the risk of some bursitis. A more or less irritating area is to go straight lateral. You basically come on the ulnar side of the ulna through this, a little bit of muscle here, and then you make a small incision with an awl, or a small hole with an awl, and then pass the rod that way. Reduction. So you pass your rod, you get to the fracture site, and you're all saying, I know how to do this for my femurs. Well, it's not quite the same. It's a little bit more difficult. So I first always will exploit an open fracture as a way for my first rod. My second choice is to do closed reduction. I usually use the ulna first. And then my third choice is go to open reduction. But you can, if you follow this progression, you can manipulate your rod with your IM nail to do some reduction maneuvers. It's not as easy as it looks in these pictures. And then I cannot harp on this enough, and I teach this every time I talk about this. But you get about 7 minutes or about 3 to 4 rod passes before I want you to stop and I want you to make an incision. Papers, certainly literature has supported that if you have increased manipulation, increased fluoroscopy time, your risk of compartment syndrome goes up. So again, this is my rule: 7 minutes, 3 or 4 passes, go right to open. It's not the wrong thing to do. And then, of course, carefully look at your x-rays. I prefer to bury my rods and remove them. Some people leave them prominent. If you're going to bury them, you got to make sure that this is not going to, the EPL is not in distress here, and this is not too long here at the ulna to cause bursitis. Do I ever do single bone? So I will do single bone when one of the bones is a incomplete or green stick fracture and one of the bones needs a rod. So I'll place the rod, I'll do a closed reduction maneuver, and if the other bone lines up, I stop. Advantages are less OR time, less risk of infection, less nerve or tendon injury. So this is one I will use, but not, I would say, about 20% of the time. Post-op, after surgery at mid-overnight, compartment syndrome is certainly what you're concerned about. I prefer a long arm cast after surgery. I see them at a week, I see them at 4 weeks. I've shifted to a short arm cast, and I like to remove their pins in the OR. It's relatively straightforward to take out unless you did not cut it correctly and you cut it too short. But either way, it is an open operation. It's one of the arguments to take these out in the clinic. And finally, complications. So remember, delayed union can happen if you use IM nails in older children or you distract across, and the answer is plate. EPL rupture has been described when the dorsal approach to the radius has injured or went on your approach, or you've entrapped the EPL. It's a attritional rupture. It is fixed with an EIP transfer. Neuritis occurs if you make the radial approach, and it's actually quite a difficult problem to deal with. It's not common, but neurolysis or some other nerve thing, but fortunately it doesn't happen commonly. And then finally, compartment syndrome. If I were ever writing these tests, I want you to know that if you go to the OR within 24 hours of injury, or you have a prolonged OR/fluoro time, your risk of compartment syndrome is increased in this particular group of patients, and fasciotomy is the answer. So in conclusion, most are treated with casting. IM fixation for skeletally mature or unstable fractures, open fractures, plate and screws for adolescents. Thanks, Josh.
Great. Thanks, Marty. We're going to switch gears a little bit from fractures and talk about other trauma. So I'm going to turn over to Teresa Wyrick from Arkansas, who's going to talk about amputations and replantation in children.
Thanks, Josh. Can you let me know, can you hear me and see my slides?
Yep, you're all set.
Perfect, thank you. Thanks for having me. So we are going to move on to kind of talk a little bit more about amputations and the treatment of that. And so, let's see. There we go. So the points that we're going to hit are going to be talking about some classification and descriptive characteristics, and then moving on to treatment and talking through the idea of the reconstructive ladder and how it fits into our treatment here. So obviously, you've seen some information tonight, and if you cover any sort of emergency room for children, you know that pediatric fingertip injuries are very common. There are different mechanisms of injury. Oftentimes they fit into the crush or crush avulsion type category. Most of the time, they are treated in the emergency room, and many times, at least at our institution, the ER management is often started at least by the resident, and that can determine what options you have going forward. And so sometimes what is done early on is often definitive and dictates the ultimate treatment options and outcomes. So it's important to really be able to think through the options and recommend the best treatment for the patient from the get-go when you first see them in the emergency room. Looking at classifications, we classify these as transverse, volar oblique, or dorsal oblique as far as injury patterns. And then going on, looking at whether or not there's exposed bone. And basically, this is how I ask my residents to describe the injury to me. And I think that says everything that you need to say, because it helps you walk through immediately what the picture is clinically of the patient and what your treatment options are. So looking through the treatment, if there's no exposed bone, certainly one option is if there's enough soft tissue to perform a primary closure. Certainly children have lots of healing potential, and so healing by secondary intention is a mainstay of treatment as far as what we do as well. Composite grafting, where the fingertip is completely off, and you may or may not defat the fingertip that's left and replace it with some dissolvable sutures to get some coverage and contour over the tip of the finger. Really, I would say that there's not a big role for full thickness skin grafting in pediatric fingertip injuries because of all of the options of what's been listed above that. So we really don't do that very much, if ever, in children. We always talk about complications, particularly in adults, about the idea of diminished sensation and high incidence of cold intolerance, but that doesn't really seem to be what we see in children. At least not something that they are aware of or complain about, fortunately. There is the complication of a hook nail, which it can be a real issue. And so when trying to do some things to prevent that, you want to avoid pulling the nail bed tightly volarly to try and cover the bone. And then also you want to make sure that there's adequate bony support for the nail. We usually say if there's half of the distal phalanx that remains, that's enough bony support, hopefully, to prevent a hook nail. And then lastly, thinking about nail horns and spikes and irregularities in the nail plate. Certainly, one pearl is that if the amputation is at or through the level of the lunula, that careful attention to resect the entirety of the nail matrix is recommended to try and avoid these issues if possible. So if there is exposed bone, we often talk about shortening the bone, but I would say that typically in pediatric patients, because of all these other options, and again, because they're children, we want to try and preserve as much length as possible. So typically in kids, different than adults, we try not to shorten the bone. In our emergency room, we usually try and do a thorough debridement and irrigation in the emergency department with antibiotics, oral antibiotics upon discharge, and a dressing, and then follow up within 2 to 4 days for a dressing change and reassessment. If everything's looking good, particularly in these young children, we may choose to do a mitten type cast and look at them once a week until they're about 2 to 3 weeks from injury and we see good healing of the soft tissues. That's our practice at our institution. If there is exposed bone and you can't primarily close the area, or you don't have options, you don't think options for secondary intention healing are a good choice, there are some so-called off-the-shelf coverage options that you can see here. This is a patient who had just basically sort of a dorsal type laceration type injury where the nail and nail plate and nail bed were all traumatically removed, and there was exposed distal phalanx, and so we just used this bilayer Integra dressing to cover the area and preserve the length, and then came back a couple of weeks later with a full thickness skin graft. So certainly there are lots of options from that standpoint for off-the-shelf coverage options. This idea of the reconstructive ladder really comes into play when you're looking at fingertip injuries, and so it's sort of working your way up to the ladder to things that are the easiest and least invasive, all the way up to the things that are most invasive. And I think most people would agree that for simple fingertip injuries, that a distant flap is never really needed, but all of these other things short of that will come into your treatment algorithm. So we'll kind of move up talking about some local advancement flaps and some regional flaps. There's a whole host, a long list of local advancement flaps. All of them are not on here. There are certainly many that have been described. We'll talk through a few of them that I have found to be useful in my practice as far as treating fingertip injuries in children. The VY, volar advancement flap, is really good for transverse type amputations. And as you can see here, you're just advancing through a V-type mechanism, that volar surface of the skin, incising the skin in a full thickness fashion and separating that from the flexor sheath and the deeper tissues, and then advancing that distally to get good coverage over the bone to change that V into a Y. I have not found much use, although these have been described, for these lateral VY flaps. In children, the flaps just tend to be very small in my experience. And so I've found other options, but certainly it's something to know about, where the V's are on the lateral and medial aspect of the fingertip, and then they're advanced distally to change the V's into Y's to get coverage over the fingertip. The Moberg advancement flap is certainly a great flap and a good workhorse for coverage over the thumb. And the advancement is somewhat limited, probably to about 1 centimeter, and sometimes less. And it does sometimes require, or oftentimes requires, flexion of the interphalangeal joint to get that coverage. But it is a very nice flap to have to cover and advance for treatment of the thumb particularly. And it's good for the transverse and the volar oblique type amputations. Looking at some other regional flaps, their cross finger flap is very good for volar oblique amputations, and will give very good recovery of sensation over time. This is an adolescent patient who was working unloading groceries at an unloading truck at the grocery store, and he caught his right thumb on a metal V-shaped portion of the back of the door, and he had an avulsion amputation type injury to his thumb. These are what his clinical pictures look like. So you can see there's exposed tendon, there's a really large volar exposed area, and he actually had more than 50% of the distal phalanx that was intact. And so a young patient trying to work through the things that you can do, certainly there are several different options. What we chose to do for this patient, this young patient, was a cross finger flap that we lifted up from the index finger. And so you can see we sort of open it up on a hinge, leaving the peritoneum intact over the extensor tendon, and then suturing that to cover that defect over the thumb. So we got nice coverage there. And then a full thickness skin graft is placed over the dorsal aspect of the index finger proximal phalanx, as you see here. And then after that's incorporated, usually about 2.5 to 3 weeks down the road, we came back and separated the hinge of the cross finger flap, and you can see a nice coverage, and the flap is nice and vascular. And then down the road, after everything is healed, there's actually a nice, good reconstitution of the pulp of the thumb. Certainly you can see he has some dystrophic nail that was there, but very good movement and preservation of length, which we were very happy with. So certainly there are other options for that, but that was the option that I chose that worked well for us. So looking at other options, there is the reverse cross finger flap, and these seem to be often asked about on tests, these different flap coverage for fingertip injuries. This is better for dorsal type, dorsal oblique, and dorsal type skin defects. So you can see this patient has some exposed middle phalanx, which is there, and an amputation, and it was a woman, and a young woman, and she wanted to preserve as much length as possible. And so in this case, we did a reverse cross finger flap. So it's a little bit different, and you can see that the skin is sort of opened up, but the subcutaneous tissue and fat is left behind and then opened up in the opposite direction, left intact on its blood supply. And that becomes our coverage over the bone of the middle phalanx, as you can see. And then the skin is replaced back down, and then a full thickness skin graft is placed over the flap that you can see here. And so that's a nice option for dorsal coverage needs. The thenar flap is something that can be used in children, and it's best for transverse and volar oblique type amputations. And it's also best for the index and long fingers. There is a variation where you can use a hypothenar type flap for the ulnar digits. Usually we want to reserve this for young patients, and that's because of the risk of PIP flexion contractures. And so a similar sort of treatment where the flap is sutured into place to cover the amputated tip, and then we come back in about 3 weeks to separate the flap. As we said, distant flaps really don't have a major use in fingertip injuries because they're just far too bulky. So in conclusion, looking at fingertip injuries in children specifically with no exposed bone, you can easily allow that to heal secondarily. If there is exposed bones, there are options. In children, we really prefer not to shorten the bone, if possible, just to preserve as much length as possible. Using the amputated part as a graft to cover the area is very helpful in children. Dressing changes with secondary healing is also very successful just because of the tremendous ability for children to heal. The off-the-shelf coverage item of your choice, plus or minus full thickness skin grafting, is a good option. We talked about some local advancement flaps and some regional flaps that are options as well. And certainly this is not an exhaustive list of those, as we said. So certainly children are susceptible to these mangling type injuries as well. So it's not always just the smaller fingertip injuries that we see. This was a 5-year-old child who was run over by a riding lawnmower. You can see there's a lot of contamination, a large soft tissue injury and defect, multiple open fractures. And so it really requires the ability to sort of think through all of the options and moving up that reconstructive ladder to see what would work. And so in this child, this was the initial closure the night of the injury, and a fair amount of that soft tissue ended up dying, as you might guess. So ultimately, we did a groin flap for this patient to get a good soft tissue coverage over the area, and then separated the groin flap several weeks down the road. And at that point, did some rehab to get better range of motion of the fingers. And you can see that there's a very good soft tissue coverage over the area now. And then fortunately, the ulnar digital vessel to the index finger was still intact. And so we use that as our pedicle to then perform a policization for this child. And certainly working through this complex reconstruction is best done with a team approach. And so we're fortunate to have a team of surgeons who can work through this complex algorithm together. Thank you.
Great. Awesome. Thanks, Teresa. That was a great last case. We're all texting in the background. Good job. So we're going to have our last talk from Scott Cozen from Philadelphia regarding tendon injuries. Maybe.
Okay.
We see your PowerPoint. You just got to make a presentation. Okay.
Josh, just give me.
We hear you coming through.
What's that?
Everyone hears you coming through.
All right, so my internet's become unstable, so give me 1 second, okay? I'm not sure why, just give me 1 second. It worked fine for the rest of the talks. Give me 1 second. I think the entire world is on internet. How about now, Josh? Anything?
We still see little pictures of your slides. Maybe stop sharing and try again.
Nothing, Josh. Shit. You got it? Do you see it, Josh?
Scott, I see it.
You got it, Josh?
Yes.
Okay, sorry about that. For some reason in Philadelphia, the internet's become unstable, and I apologize in advance. I'm going to finish out this Zoom conference with talking about tendon injuries in children. I am going to focus on flexor tendon injuries in children because they're more complicated and I think more interesting than extensor tendons. I do need to spend a second and give a shout out to Temple University. So we are adjacent to Temple University that now has 180 COVID patients. So we posted this sign thanking the healthcare workers for all they do for all the patients with COVID. And we are providing lunch for them this week coming up. But I think it's important that we recognize those people that have given so much in terms of this pandemic, including healthcare workers, mailmen, trashmen, et cetera, et cetera. So we feel their pain and we appreciate all their support that they've given. So I'm going to talk about flexor tendon injuries. And from a demographic standpoint, the most common injury mechanism is either glass or followed by a knife. The typical case would be a kid who reaches his hand into the dishwasher and cuts his flexor tendon. The most commonly injured digits are the index and the small finger. The average age is about 8 years of age. And males are more common than females, mainly because they're more curious and they put their hand all places they shouldn't put them. Zone 3 is most common. We'll talk about zones, followed by zone 2. Now, with reference to diagnosis, I really think the best chance is in the emergency room. And for some reason, it frequently gets missed. There's a resting stance of the hand, as you see in this picture, with the long finger sustaining flexor tendon injuries, but for some reason, it does get missed. I think when there is a flexor tendon injury in a child, you need to assume that there is a concomitant nerve injury, because we all know that sensation, meaning like 2-point and Semmes-Weinstein, et cetera, is unreliable in children less than 8 years of age. With reference to late diagnosis, be careful. Kids cheat, and they will develop trapping between their uninjured finger and their injured finger. And it may go unnoticed until difficulty with a specific task years and years later. So let me introduce you to Nathan, who is what we call a cheater. He has a lacerated flexor tendon of his index finger. And if you look at his examination, you can't even tell that he has no flexor tendons in his index finger, because he traps by bringing his long finger over his index finger. But when you look at him carefully, you see that his index finger tendons are lacerated. And more about Nathan later. Now, with reference to early versus late repair, the differentiation is kind of ambiguous, but I think up to 4 weeks is okay. Flexor tendons in and of itself are not an emergency, and you can delay their surgery until it's appropriate. In this pandemic, we would still do it. We wait a couple of days, but we still operate on these kids. And be aware of what's called a pseudotendon, where when you operate, there's scar between the proximal and distal end. Late is way more difficult. Late is a reconstruction that is likely 2 stages unless the pulleys are intact. It may restore flexor function years after injury, but it is a difficult to repair these tendon injuries acutely when the results are more predictable. In terms of early repair, There's all sorts of ways to fix these tendons, but you need to modify the size of the suture and the number of strands to match the tendon size. Clearly, the more strands across the repair, the stronger it is, but at the same time, it's difficult to compare this small
Uh-oh. I think we lost you, Scott. Hold on. Yeah. Yes. Hold on, everyone. He's reconnecting. I'm going to put some. What I think I'm going to do is actually a case or two up while we wait for Dr. Kozin. And we can do it that way. So let me share my screen. So hopefully everyone can
Josh, do you have a tendon case that might bring out some principles that Scott, I'm sure, was getting to?
I did not have a tendon case in here. So maybe Christine. This is a 17-year-old football player, hurt his right thumb and had some pain in his CMC region. These were the initial radiographs, which were difficult to assess anything. I think that's the normal styloid, maybe a tiny little buckle type thing. But here it is a few weeks later when the cast was initially removed, but he continued to have pain. Do you want to, I think you kind of talked a little bit about this.
Yeah, so this is really, an adult type injury. This is a Bennett. And if you go back to the initial injuries, Josh, it really highlights the fact that when I'm seeing a thumb in clinic, I'm always sending that kid back to get a true lateral of the thumb, right? Because that didn't just spontaneously dislocate in a cast. I mean, most likely, right? So you kind of have an AP, but not an AP. You kind of have a oblique, but you don't really have orthogonal views. And so I'm constantly sending kids back to look at that CMC joint. And so, certainly, I guess, you could make an argument that if it's well reduced, you can put it in a well molded cast. But obviously, at this point in time, this is, dislocated. You can see that little piece right there. And, it's a Bennett with a really, really small piece.
Yeah, so are you gonna bite or he's having pain, so.
Yeah, so I am gonna bite on that. I would plan on doing an open reduction and seeing if I can get that lined. Well, and see if I can get that lined up. See, you did it before I even said, and try to fix it. Obviously, if that piece is so small that I can't get a pin across there, then I might consider, putting a suture anchor and trying to imbricate that, kind of volar oblique ligament to get that to stay. And I think what you did is fine pinning the first to the second, or, I would probably pin the first metacarpal to the trapezium, but I mean, it's like, 6 dozen of one, half dozen of another. There's a lot of ways to skin a cat, but I mean, this looks pretty good and I'd be pretty happy with that.
And maybe one more, sticking to our theme here, 13-year-old who was playing baseball 4 weeks ago and someone ran into him. You talked a lot about remodeling towards the base of the first metacarpal. Is this something that remodel?
Well, looking at this again, it's those 3 views of the hand, but you never really see a lateral
to see, to me, I'd be concerned that that metacarpal is totally 100% displaced. It's foreshortened, it's totally off. Yeah, see, and then there you go. That is that type C that we talked about, that especially in a 14-year-old who doesn't have that opportunity to remodel, I would just book that for surgery to reduce and thin it. And I would say it is amazing how fast these heal. I have had to open these at just a week out because the healing is so amazingly fast.
Yeah, so this required formal open reduction and internal fixation. Okay, so I'm going to stop sharing because Dr. Kozin is back. We think. We see his picture, so we're going to share.
Give me a second. Do you see it, Josh?
No. Yes, uploading.
What's that?
Yep, you're up.
Yeah, I'm sorry about that. It's amazing. It gives you an idea how many people are using this type of program to teach, actually, which is probably a good thing. So I'm back to early repair. So zones 1, 2, 4, and 5, repair is more predictable than zone 2, where there's 2 tendons. Be careful when you have something in zone 1. You want to make sure that when you put a button through the distal phalanx, that you avoid the physis. And then with reference to suture configuration, there's lots of dialogue and discussion about whatever works for you. I think it's whatever best and you're more comfortable with. We use a cross-lock cruciate 4-strand repair with a non-absorbable braided suture. We also add an epitendinous suture using a 6-0 suture. But again, this is a little bit of dealer's choice. This is just our preferred configuration for kids, flexor tendon repairs, and most likely adolescents. With reference to postoperative regimen, compliance is always an issue, and it's age dependent. What's the worst things that can happen? Number 1, a rupture of a tendon. But next to worst, number 2, is a tendon that's adheres to the bone or to itself and requires subsequent tenolysis. I would rather have a 2 than a 1. So in older compliant children, which may be an oxymoron, that early controlled motion is applicable. In a young child, the treatment is immobilization with a wrist inflection, MCP joints inflection, IP joints straight for 3 weeks. It's been shown that 3 weeks is the appropriate amount, and greater than 4 weeks leads to increased stiffness. So when in doubt, immobilize. If there's any question about the compliance of the child, I recommend you put them into a cast. If you look at the results of early acute repair, if you look at children, they tend to do better than adults, just like most things. And if you fix them with primary suture and controlled mobilization, 80%, give or take, excellent or good results. Again, you want to try and repair both the FDS and FDP tendons when they're both cut. And you want to try and avoid tendon ruptures, and you want to try and avoid tenolysis, both by early mobilization and subsequent late mobilization. So here's an example. This is Selena, who was a 13-year-old girl visiting her father's graveyard when a tombstone fell directly on her hand. She had a finger laceration. She shows up 2 weeks later to the office because the family is grieving, meaning that she didn't show up right away because there was some concern about the grieving in the family. But she's still relatively acute. Her sensation was intact. We did a standard exposure of the flexor tendons. As you can see by her cascade, it's obvious that both her FDS and FDP are cut. There was a laceration over the A3 pulley. The tendon was retracted past the A1 pulley. What you want to do is avoid disrupting any more pulleys. So here you see the freer elevator placed beneath the A2 pulley. The tendon's being retrieved. The FDS is repaired with a 4-stranded cross-lock cruciate technique and a 6-0 nylon epitendinous. And the FDP is repaired in a similar fashion with a 4-strand cross-lock cruciate using a 4-0 fiber wire and then additional epitendinous suture. Her outcome was good, not great. She had a small flexion lag to the distal palmar crease, but she had full MCP joint and IP motion, which bodes well for hand participation. Now, late reconstruction is difficult. So first and foremost, it's not an easy operation. It has an increased complication rate both in children and adults. If you look at adult literature from Peter Amadio and others, only about 50% obtain adequate results using a stage tendon repair. So it is not an easy task. Here's an example of a child that we did, Nathan, who's kind of a childish. He's 17-year-old. He lacerated his right index finger at 2 years of age. So he was a child I showed who was the cheater earlier in my talk before I lost internet connection. And he failed flexor tendon repair. And now he's 17. And what does he want to do? He wants to become a Navy SEAL. And he needs to shoot with his index finger to shoot whatever, rifles and guns, et cetera, et cetera. This is the examination I showed you previously. So again, he's a very good cheater. If you look at Nathan's examination, it appears that his index finger is flexing, but what he's doing, he's capturing his index finger with his long finger, and he has no independent flexion of his index finger, which he needs for shooting his gun and pistol, etc. So we performed the stage tendon reconstruction. Here you can see the silicone rod being placed beneath the pulleys, and pulley reconstruction was performed at the same time. For a donor, it's interesting. We typically use the rest of the flexor tendons as a donor to allow for composite flexion. But since he needed independent index finger flexion to shoot the gun, we used an ECRL that was split in half to add length. So if you understand, so the index finger needed to shoot separately from the long and ring and small finger. So he used a split ECRL tendon that was split in half like a Twizzler. He was doing great, which is never a good sign. And then he felt a tendon rupture as he was pulling the trigger, and subsequently we went back because you can't give up on these kids. We found that there was a rupture between the ECRL split. We repaired it and started him back in rehab. And here he is at follow-up. So there is some flexion posturing of the DIP joint, but there's good composite flexion of the index finger. And here he is demonstrating his motion. So his ECRL is motoring his stage flexor tendon of his index finger with relatively good motion. And here he is demonstrating that he can shoot with a gun, although we don't allow guns in the hospital. So this is the best that he could do, but you can sense what he can do. And he subsequently went on to be a Navy SEAL. So in conclusion, principles for flexion tendon surgery are applicable to kids. You want to repair them early. You need to modify your suture technique secondary to the small flexor tendon size and lack of compliance in the postoperative rehab. And stage reconstruction is possible, but I can tell you it's extremely difficult and fraught with complications. Thank you very much and be safe.
Great. If you can stop sharing.
Yep, I'm on it.
Awesome. Thank you very much, Scott. I'm just going to put up for 2 more minutes here the websites. In case anyone needs them, and then we will stop and end this webinar. We ran a little late, obviously some technical issues. Sorry about that, everyone. But we will be back next Sunday night with congenital pediatric upper extremity. Again, another high yield topic for test questions. And thank you all for your patience tonight. And again, here are the links for upcoming webinars, both hand and upper extremity and then pediatric orthopedics. Thanks again and stay safe.